أنا هتكلم النهارده it's a sponsored session من Novartis. I'd like to thank them for inviting me. هتكلم على CDK4/6 as a first line في الميتاستاتيك setting, وهتكلم كمان على we're going to discuss a case of mine. These are my disclosures. دي بس historical background كده, how the picture was like لما أنا كنت نايب more than 20 years ago. We offered the patients with metastatic hormone receptor breast cancer either tamoxifen or aromatase inhibitors. We did not have the luxury that we have today. Only two options, either tamoxifen or aromatase inhibitor. Aromatase inhibitors were quite expensive, very expensive أول ما طلعوا. However, they were reasonably effective in that they achieved survival for these patients, metastatic cancer patients, of around 2.5 to 3 years. If you're giving tamoxifen, average survival is 30 months. If you're giving aromatase inhibitors, it's around 2.5 or 3 years. Things improved significantly in breast cancer, in HER2 particularly, with the anti-HER2 treatments, trastuzumab, pertuzumab, and the different, I was just talking this morning, we have 9 FDA approved treatments for HER2, but things were stagnant in luminal breast cancer until 2015. 2015, we had the first representation of the prototype CDK, which was a palbociclib. I remember I was attending this session in the ESMO 2015. Nicholas Turner read out the results of the Paloma 2 trial, which was amazing result, showed a significant improvement in progression-free survival, response rates, and it ticked the box for the primary endpoint. Then we had a plethora of data coming from the Mona Lisa group, the Monarch group, first line, subsequent lines of treatments, and we've seen a couple of things. We've seen, number one, that we have definite improvement in the results of our metastatic hormone receptor breast cancer patients. Secondly, that the primary endpoint, the hazard ratios, as you can see here, and the progression-free survival were identical. So this improved our confidence into the 3 molecules. In terms of primary endpoint, PFS, and the hazard ratio was the same. The control arms, as you can see here, were exactly the same, which tells you that these cohorts of patients are very similar to each other. 14.5 months median progression-free survival with hormone alone in the control arm. And in the investigational arm, we've seen for the first time numbers exceeding 2 years of disease control on the first line. Response rates exceeding 50%. So this established the role of CDK4/6 inhibitors as the main standard of care in the first line treatments, and in those patients who do not get the chance to get CDK in the first line, they should have it at the second line, but no patient should go through first line, second line without any exposure to CDK unless it is contraindicated in this case. Another thing which is very important for our metastatic cancer patients, particularly ladies, is the alopecia and the side effects of chemotherapy. So another additional advantage from giving a CDK4/6 is that they prolong the duration until you give chemotherapy. If you're not giving CDK4/6, you would expect in average to offer chemotherapy after 2.5 to 3 years. Here with the CDK4/6 inhibitors, we see that CDK4/6 can push the time to chemotherapy, delay the need for chemotherapy by another year gained without alopecia, significant nausea, and the other unwanted side effects of chemotherapy. Kaplan markers, you can conclude many results from the Kaplan markers. First, there is clear separation. Second, it's an early separation. After just 2 months of treatment, you start to see considerable changes and considerable improvement. Number 3, that the separation is ongoing. It's not transient. There is no convergence of curves. It is ongoing. Hazard ratio, as I said, 0.5, very good. But in metastatic cancer patients, we want to see survival. Unfortunately, we cannot cure breast cancer patients until date. But if we cannot cure them, we want at least to improve their survival. We want them to live for as long as possible. So what about overall survival? Did it improve? So again, palbociclib, the first one, the most commonly used from 2015 until 2020, was the first one to announce the overall survival. And unfortunately, disappointingly, the results were negative. No improvement in overall survival. The study group tried to figure out why. Is it the statistical design of the trial? Is it the lack of follow-up? Patient missed to follow-up? Is it the lack of documentation? So they looked at different things, but at the end of the day, the result is the result. There is no improvement in overall survival. On the other hand, this was disappointing to us as the oncology community. However, the Mona Lisa read out later and in the subsequent ESMO, and actually it showed an overall survival improvement in the Mona Lisa 2, in the intention to treat group and in the all group. And we were wondering whether this is a result, temporary result, or a result by chance. The Mona Lisa 2 was almost same design, ribociclib in this case, plus letrozole versus letrozole alone, randomized in 1-to-1 manner, and the primary endpoint is PFS, secondary endpoint are the usual ones, overall survival response rates, quality of life, etc. So there was a significant improvement in PFS, but more importantly, there was a significant improvement in overall survival with a hazard ratio of 0.76. It improved survival by 24%, by a quarter, and this was statistically significant this time. So we started to wonder, is this by chance? Is this transient? But we were reassured later on with the updates of the data. We've seen over the years that the improvement in overall survival was not only maintained, but it was actually improving from 5.7% to 8.4% and up to 12.2% at 6 years. This is for the Mona Lisa 2. So was it a coincidence? No, because we've had afterwards the results of the Mona Lisa 3 in the sensitive group. We have the results of the Mona Lisa 7 showing that with all the trials, including ribociclib in the first line setting and also in the second line setting, there was an improvement in overall survival. So what about the third player, abemaciclib? Abemaciclib showed very good activity as well, but I want to highlight a couple of differences. Abemaciclib, it was a smaller trial, 400 and something patients, 493, in comparison to more than 600 in the Paloma and in the Mona Lisa. And it is a 2-to-1 trial design. It was not 1-to-1 fashion. What about the overall survival? Overall survival improved also significantly from 53 months to 66 months, more than 1 year. Nevertheless, this was not statistically significant. The p-value was 0.8 and the hazard ratio was 0.8 and the p-value was 0.06. So it is what we call in medicine clinically meaningful, but statistically not meaningful. What does this mean? It means that we feel, it's a feeling that it's an active drug, it's a good drug, but we're not standing on solid grounds because statistics do not mention the same, do not coincide with the same, do not agree with the same. So it is numerically better, but statistically it's not better. On the other hand, as I said, in the median overall survival in the Mona Lisa, it exceeded the 5 years, so patients are living more than 5 years. That's why when I see a patient in a clinic, I tell them it's more of a chronic disease rather than a lethal disease. We used to count survival in months before. Now in the era of CDK, we're talking about years. More than 5 years median survival. Personally, I have few patients on ribociclib and abemaciclib, by the way, living for 5 years and 6 years. So we're seeing definitely a significant improvement in survival of our patients. This happened despite the fact that in these trials, upon progression, the investigators offered ribociclib. So still in the control arm, this difference happened in overall survival despite almost half of the patients receiving ribociclib upon failure, which tells you two things: that the drug really works and is very active. Secondly, if you do not give it in the first line, you should be giving it at least in the second line, but optimally in the first line, because if you give it in the first line, you see better overall survival. No new safety signals. You've been using the CDK4/6 now for more than 8 years. Neutropenia is the most common, particularly with ribociclib and palbociclib, followed by transaminitis, slight elevation in the liver enzymes. Prolongation of QT interval, this occurs in around 5 to 7% of our patients. And there are very rare side effects, but you have to also be aware of, like interstitial lung disease or pneumonitis. Again, this is a comparison of the 3 trials. As you can see, with the ribociclib and palbociclib, the study was they were large studies, 666 patients, bigger than the abemaciclib trial. Randomization was 1-to-1 in the Mona Lisa trial compared to 2-to-1 in the other 2 trials. Because of its overall survival improvement, the ESMO in their guidelines, in the magnitude of clinical benefit scale, this was the only agent given a score of 4 for the first line. If you look at the Paloma 2, given score 3. If you look at Monarch, it was given also a score of 3. Why? Because they did not achieve overall survival improvement. When would you get a score of 5? Not 4. This one improved PFS, improved OS, and it was given a score of 4. When would you see an agent getting a score of 5? When it also improves the quality of life, not only maintain it, but also improve it. And this happened actually in the premenopausal trial, the Mona Lisa 7, where it was not only a matter of improving progression-free survival and overall survival, but also improve the quality of life. That's why they were given the top score, which is 5. The only CDK that was given a score of 5. That is why the trend it shifted universally. Most of us were using palbociclib because it was the first one to come to practice. But then we started to shift. This is a snapshot from the ASCO. I took it with my mobile, where it showed, actually, this is Daniel Stover from the Marsden, from MD Anderson, saying that in most patients now, they use the ribociclib, but in selected patients, they would consider palbociclib or abemaciclib. So why this happened? Why do we have an overall survival improvement despite we have similarity in PFS and close chemical structure of the 3 molecules? Well, to cut a long story short, we don't know why this is happening, but there are different theories. One theory is, I mentioned it earlier already, it could be the trial designs. This is 1-to-1, the only trial randomized 1-to-1. It had very good patient follow-up registry. This was more than 600 patients, unlike the abemaciclib, which was a smaller study. It could be, but this is not confirmed. It could be the pharmacodynamics of the drug. Ribo and abema, they are structurally very different than palbo, and the 3 are structurally different than each other. They have different CDK4 to 6 affinity. For example, ribo and abema, they have more affinity to CDK4 rather than 6, and the free drug exposure is significantly higher with ribo in compared to palbociclib. Is this the reason? Maybe, but again, it's just food for thought. We're not entirely sure. Others went to look at the biology of the disease, like these groups. They looked at the different subgroups of luminal breast patients. Not all luminal breast patients are the same. What we think are ER positive, HER2 negative are not always like that, and not always behaving like luminal breast cancers. So the Mona Lisa group, they looked at older groups also. When they used the genomic profiling to characterize the tumors, they noticed that some tumors are HER2 enriched, and some tumors are basal-like. They behave like basal-like tumors. How come? And they are ER positive, HER2 negative. This is genomic profiling. This you notice and you learn if you do full genomic profiling of the tumor. But if you judge by the outlook of the cancer cell, what the phenotypic type, the histopathology, they all look the same, ER positive, HER2 negative. But if you do full genomic profiling, you notice that they are not the same. You have the HER2 enriched and the basal-like, which are very aggressive. As you can see here in the Kaplan-Meier curves, the true luminal A and the luminal B do much better than the basal-like and the HER2 enriched. In the Bolero 2, regardless of the CDK and and the newer data that we're talking about, in the older trials like the EGF 3008 and the Bolero 2, when they looked at the patients who are truly luminal versus patients who are HER2 enriched or basal-like, the truly luminal, they always do better. So how does this relate to what we're talking about today? The Mona Lisa group, they went back and they looked at the tissues, and they've done comprehensive genomic profiling. They noticed that around 15% of the patients were HER2 enriched, the more aggressive subtype. And we know from other groups that actually palbociclib do not perform as well in these groups. It does not perform at all actually in this group. But what about ribociclib in this group? As you can see, the luminal A and luminal B, the delta difference in progression-free survival is 10%. Even in the HER2, it is 10%, although the response with endocrine therapy alone is 5%. The PFS is 5 only percent. It improved, but so it was almost tripled by adding ribociclib. So, in a nutshell, ribociclib performs well not only in the truly luminal, but also in the aggressive subgroups of ER-positive, HER2 negative patients. Did this translate into overall survival improvement? Yes. Those patients had survival improvement despite their aggressive nature. Basal-like, they do not improve whether you give CDK, hormone therapies, they always need chemotherapy. But the only way to know about basal-like is to do comprehensive genomic profiling. Palbociclib, as I said, in this subgroup of patients, when they've done comprehensive genomic profiling, they noticed, as you can see on the left in the first line, palbociclib did not do any difference in this subgroup of patients. Another theory, so these are three notions so far that could explain. The fourth is that other groups, they looked at what happens with tumor over time. And we've known, again, from literature that the breast cancer, it changes its biology over time to more aggressive nature. There is shift and drift in the tumor. The Aurora group, one of the most famous to study this. And they showed that in most cases, the cancer changes into a more aggressive type. So if you have luminal A, they switch to luminal B, they may switch to HER2, a positive breast cancer. Okay? So in these patients, the prognosis become worse with time. What other groups using ribociclib noticed that actually if you give ribociclib, like in this phase 2 trial, the Coraline study, they noticed that actually ribociclib does not only prevent this from happening, but it actually can reverse the biology of the cancer. So you can switch luminal B to luminal A. So this is another notion which could explain why we're seeing the survival improvement. Finally, before I go, I'll just demonstrate one of the cases that I treated recently, just to highlight a couple of points. This is a lady, 68 years, a very fit lady, but she's not this lady. We don't have very fit ladies like this in Egypt, unfortunately. But she was very good for her age. Compared to her age, she was very good. Well-controlled hypertension, no allergies. She doesn't have any history of cancer. Civil engineer, widow, lives alone. She has one daughter who lives in the UK, so she lives alone. She's independent, so we were very keen to keep her independent. Performance status excellent, ECOG 0. And she felt a right axillary lump in the beginning of 2022. She ignored it initially. It went on increasing in size. The lump increased, causing some puckerings. She went to a surgeon. Surgeon rightly requested bilateral mammo and ultrasound, which showed there is breast cancer and spread to the axillary lymph nodes. Radiological staging, T3N2. She has a large tumor and axillary lymph node were positive. He requested also PET-CT, and the PET-CT showed that the tumor has spread to the bones, extensive disease in the bone. Studded liver, the liver was looking very, very heavy with metastasis. Metastatic lymph nodes in addition to the breast and the axilla. The biopsy showed that it's ER8, PR7, HER2 0. Initial CA 15.3 was 59. So she came, we met her, we noticed that her liver enzymes were slightly elevated. With a studded liver, we were concerned about impending visceral crisis. She's not truly in visceral crisis, but we were concerned with the slightly elevated liver enzymes. So we started to think, shall we play it safe and give her chemotherapy? By the way, this was before the data of the right choice. We were thinking whether to give her chemotherapy or ribociclib. Then we said, okay, let's give her ribociclib and see what happens. Aim of treatment in this lady, two main things. First, she's 68, she's living alone, so we want to maintain a good quality of life. Second thing is we want a rapid disease control because she has extensive liver disease. This is a snapshot from her notes actually, and this was our plan in June 22. Review bone and deliver radiotherapy if needed, start ribociclib and Femara, denosumab for bone metastasis of course, but as you can see the statement at the bottom, we have low threshold to switch to chemo if she shows signs of visceral crisis. First question to ask, was it safe for us to do so, to offer this lady a ribociclib or not when she has extensive visceral disease? Secondly, is it good in her age? Is the data reliable in an age of 68 or 70 as it is in the young? As I mentioned before, right choice answered this question. We've seen the results in, I think, 2023. It was reassuring. It showed us that if you give these patients, similar to this lady, ribociclib, you're actually outperforming chemotherapy. You're not only achieving same as chemotherapy, you're outperforming chemotherapy in almost all aspects. So in terms of progression-free survival, 2 years versus 1 year. In terms of response rates, higher response rates. And the thing that we are very concerned about is time to response. It was almost the same if you give ribociclib. So there's no real advantage giving chemotherapy in this lady. What about the elderly? We had a plethora of data on elderly, not only with ribociclib, but also with palbo and abema, and they showed us that this class works very well in the elderly patients. The Mona Lisa group, they've done this data, I think it was in the San Antonio last year, where they showed that in the elderly patients, above 65 or even 75, PFS benefit was maintained across all groups. Same for overall survival. Time to chemotherapy, very important, especially in patients more than 75 years. As you can see, very big difference. You can delay chemotherapy by giving this. I'll skip these. So what happened to our lady? She started ribociclib and Femara. We started to see the liver enzymes dropping, alkaline phosphatase dropping. QTC was near the borderline, but was acceptable. And this is her first imaging after 3 months. Significant improvement, almost metabolic clearance in the bone, almost metabolic clearance in the liver. We went on imaging her and doing blood tests, and despite the scans showed very good response, but we noticed that the liver enzymes were shooting up. So it did not make much sense. So we realized that this is probably the drug, not the disease, because the disease is receding very nicely. So what we've done is that we introduced a dose reduction to 400 milligram instead. She went on 400 milligram from September 2022. This lady, I've just seen her last month, and she brought with her the last PET CT in November 2024. So we're talking about almost 3 years now, more than 2.5 years. On 400 milligram, she has no evidence of disease. Complete response in the breast, the lymph nodes, the liver, and the bone. So it's another success story for this class of treatment. And with this, I conclude. Thank you. Any questions? I have patients 5 years and 6 years. Not only, to be honest, not only with ribociclib. I have also success stories